Few announcements and then we'll get started. I'd like to welcome everyone to Cardiology Grand Rounds. This is the final Grand Rounds of the year, and we're going to go out with a bang with Dr. Pengyang Li presenting on a topic that he is, as a fellow, uniquely an expert on. He's going to talk about Takotsubo syndrome, specifically secondary Takotsubo syndrome. Before we go ahead and start the talk, I'd like to share a few things about Dr. Li. We have the good fortune of him starting as our advanced heart failure fellow next week. He is coming to the table with an excellent training background. He completed his medical degree at the Peking University Health Sciences Center, went on to do his postdoctorate in Texas, and completed his training here as a general cardiology fellow just this week. He's had numerous publications, and if you look up his name, you'll find extensive expertise in areas such as Takotsubo, including a JACC publication, and numerous other cardiomyopathies, and also translational research. He's had the unique success of developing collaborations at all of the centers he's at, maintaining those connections and continuing publishing work. And his niche in research is really related to big data. So for those of you here initiating projects or consider reaching out to Pengyang if you're interested in your area of expertise and want to do research with high volume data sets. So I'll stop here. I'll hand this over to Dr. Li and look forward to learning from him. Thank you, Pengyang.
Thank you, Dr. Shah, for the candid introductions. Welcome, everyone. And today I'm going to talk about a secondary Takotsubo syndrome update. We'll start with excuse me. And we'll start with some background information and the diagnostic criteria. Then we'll talk a little bit about the secondary versus primary Takotsubo syndrome. Then we'll focus on some recent update on the specific trigger-induced secondary Takotsubo. Takotsubo syndrome was first reported in Japan in 1990. Kido published 3 case series with apical ballooning type cardiomyopathy who had the normal coronary artery. So at that point, they thought it is due to multivessel spasm caused the stunted myocardium. So since then, there are several different diagnostic criteria proposed by different society. So in 2004, the Mayo Clinic proposed the Mayo Clinic criteria for apical ballooning syndrome. They emphasize the transient nature of the left ventricular dysfunction, either hypokinesis, akinesis, or dyskinesis, and absence of obstructive coronary artery disease. Also, phenochromocystoma and myocarditis need to be excluded to make the diagnosis. Stress events could be present, but not always. Then in 2016, the ESC Heart Failure Association had proposed another diagnostic criteria. The major changes is instead of only focused on the left ventricular, RV involvement has been recognized in the 2016 diagnostic criteria. And for obstructive coronary disease, it emphasized the absence of current coronary artery disease that could explain the temporary left ventricular systolic functions instead of including all the obstructive coronary disease cases. And in 2018, the ESA further updated, modified the criteria with including phenochromocystoma as a secondary causes of Takotsubo. Here we can see from here, phenochromocystoma can be triggers for Takotsubo syndrome. Again, it emphasized the significant coronary artery disease is not contradictions in Takotsubo syndrome. So what is secondary Takotsubo? So primary and the secondary Takotsubo can be differentiated based on the clinical scenario. So primary Takotsubo means those who presented with acute cardiac symptoms, and those symptoms are the primary reason for care seeking. Most of the patient may or may not have any identifiable stressful triggers, and most of the time are emotional. Secondary Takotsubo are considered as acute cardiac complications from another primary medical condition, either like surgical, medical, and it's usually happened in hospitalized patients. So why it's important to differentiate between secondary and primary Takotsubo? So first, secondary Takotsubo account for around 40% of all Takotsubo cases. As we can see from here, almost every single system disease can trigger secondary Takotsubo. It accounts for around like 36 to 41%. And usually, secondary Takotsubo have worse outcomes, as we can see from here. This is a study compared with 300 secondary Takotsubo patients with primary ones. They find secondary Takotsubo has a higher mortality with 12.7 versus only 3% in primary Takotsubo. They had a higher MACE, 34% versus 26, and also a higher recurrence rate, 28 versus 17%. This is the survival curve. We can see clearly there's the like differences after 80 months of follow-up. Also, secondary Takotsubo often presented with atypical features. Instead of affect mainly of post-menopausal women, secondary Takotsubo can affect both men and women. It usually happened after the organ disease, and most of the patient may have coronary artery disease at baseline. They usually have more severe LV dysfunction and with late recovery and worse outcome. In terms of pathophysiology, there are several mechanisms has been studied in Takotsubo syndromes, include catecholamine surge and the brain-heart axis, inflammations, coronary vasospasm, and microvascular reactivities. So in primary Takotsubo, the major mechanism are likely from the reversible macrovascular dysfunctions from the catecholamine surge. Or for secondary Takotsubo, it's usually from the direct myocardial damage from the catecholamine injury or inflammation. But still, like this field needs to be further explored. So there are several triggers has been reported that can cause secondary Takotsubo. This is a very good summaries from European Journal of Heart Failures, which include the most like every single system disease, which you can see from here, and medication. Majority of those information are from the case report. So recently, there are more study focused on the trigger-specific secondary Takotsubo. So next, we'll talk a little bit about the recent research on the secondary Takotsubo with specific triggers. We started with COVID-19. This is a study done by our research group. We utilized the national inpatient data samples, identified all the patients, COVID-19 patients, hospitalized COVID-19 patients, and who had a secondary diagnosis of Takotsubo. So a total of more than 200,000 patients hospitalized for COVID-19 was identified. There are like 171 cases have a secondary Takotsubo diagnosis, which is very rare. It's only account for like 0.08%. Then we did a propensity score matching their baseline character and comorbidities. We find compared with those who do not have Takotsubo, the one who developed Takotsubo much higher mortality, 30% versus 14%, and also much higher mechanical ventilation, 34% versus 10%, much longer hospital stay, and much higher hospital-related costs. In order to further explore the features of Takotsubo in COVID-19, we did another study, systemic review articles. So in total, we find 78 patients who had Takotsubo secondary to COVID-19. We further compared this patient group to Takotsubo due from acute respiratory disease and to those who have no anything like respiratory disease. Interestingly, we find in Takotsubo's secondary to COVID-19, there are only like 23% of patients who presented with chest pain. Well, the other Takotsubo, not from respiratory disease, had like 78%. And Takotsubo, due to acute respiratory disease other than COVID-19, had a 52%. So we can see from here, like COVID-19 patients who had a Takotsubo usually present with very typical symptoms, with less chest pain, and they have more that shortness of breath, 70%. Even compared with those due to acute respiratory disease other than COVID-19, they have different clinical presentations. Yeah. Also, the basal tap, which is a typical tap of Takotsubo, are more frequently seen in COVID-19 Takotsubo cases, account for 11%. And here is the outcome. We find Takotsubo secondary to COVID-19 had a mortality rate of 26%, while those with no respiratory disease only have 4.2%. And those with acute respiratory disease have 5.7%, which is quite similar to our previous studies, around like 20 and 30% of mortality rate. So from those two studies, we can learn that Takotsubo is very rare in COVID-19 patients, but they can present with atypical symptoms with very high mortality. The next one, I want to talk about a vaccine and the secondary Takotsubo. So since the introduction of COVID-19 vaccines, especially the mRNA vaccines, there are several case report systemic review on the COVID-19 vaccine induced the Takotsubo. So we did a study trying to explore more about vaccine and the Takotsubo syndrome. We use keywords like Takotsubo and the vaccine to identify all vaccine-related Takotsubo. In total, 19 patients are identified in 18 publications. So most of the vaccine are from COVID-19, with 82% are mRNA vaccine. And there are 2 cases from influenza vaccines. So the average time from vaccine to symptom onset is around 2 days. Most of patients presented with very typical symptom with chest pain, short of breath, but more than half of them also have some atypical presentations with fatigue, diaphoresis, or fever, or digestive symptoms. 2 patients died. So those 2 patients are young males at age of 15. So the diagnosis was made after autopsy. So the death rate is quite high, 12.5, but given the limited sample size, So I think from those studies, we can see that it's very rare to have vaccine-induced Takotsubo, but it could happen. If patient presented with very typical symptoms, Takotsubo should be considered, yeah, especially in those like young male patients. The next topic is Takotsubo and medications. It is well recognized that medications can cause Takotsubo, but which which one and like also like what class of medication most likely to cause Takotsubo need haven't been like well studied. So in 2022, this is a study from Japan. They utilized the Japanese adverse drug event report identified 300 Takotsubo cases that due to medication. They find 58 cases are from adrenergic agonist drug with a high predominant of women, 89% in the age of 70s. Even after adjustment for the age and the sex, most of the intravenous catecholamines still have a significant higher reporting ratios for Takotsubo, which means they are more likely to cause Takotsubo syndromes when compared with other medications. We also did a similar studies which has been presented during the ACC meetings using the FDA adverse effect database, and we find more than like 4,000 cases of Takotsubo secondary to medications. Clearly, there's an increased trend of medication-induced Takotsubo since 2005. And among the 4,000 cases, the top one is epinephrine, followed by venlafaxine, then propofol, and 5-FU albuterol. Interestingly, we can find like each of those medications, they all have potential like mechanism that may involved in the development of Takotsubo. Like venlafaxine, which is SNRI, it will increase the brain levels of norepinephrine, which may affect the brain and heart crosstalk. And propofol and the 5-FU may directly cause inhibit of myocardial dysfunctions. Again, the mortality is much higher than primary Takotsubo, which was around like 4%. The medication-induced Takotsubo had a mortality of like 7.9%. Next, I want to talk a little bit about secondary Takotsubo and surgery. Surgery, this is a study published last year with 100, around 100 cases of surgery-induced Takotsubo. So they find that the mean age of perioperative Takotsubo was like 55. Around 50% of cases are happening during general or transplant surgeries. And 67% of the case occur post-operatively, usually within 24 hours. And the chest pain were less common in perioperative Takotsubo patient, which is quite interesting. And most like every single secondary Takotsubo patients have like chest pain symptoms. 84% have improved symptom with conservative medical management, around like 15%, which is quite high, require mechanical circulation support. The mortality rate is also around like 7%. This is a study by our group, and again, we find similar findings like chest pain is pretty less common in surgery-induced Takotsubo, only like 30%, when compared with all type of Takotsubo, like 75%. Among all the different surgery type, intra-abdomen surgery account for like 49%, followed by the cardiothoracic and vascular surgery, 24%. Then the ENT and ophthalmology, 12%. 8% neurosurgery, and 7% orthopedic surgery. Also, the basal tap, which is the atypical one, is more frequent, say, in surgery-induced Takotsubo. Last, I want to talk a little bit about Takotsubo in heart transplant for some obvious reason. So this is a very interesting study. So this study is focused on patients who received donor heart who had transient left ventricular dysfunctions. So the research group identified those donor heart who had previously reduced the left ventricular systolic functions, but improved later on and got transplanted. 472 cases are identified. Then they further classified those patients into different subgroups based on the different wall motion abnormalities. They call the Takotsubo-like hypokinesis, which is a apical ballooning tap, regional wall motion, versus those who had a regional wall motion abnormality but not the apical ballooning tap, versus those had a global left ventricular hypokinesis. I think it will be more accurate to call it like apical Takotsubo-like hypokinesis, since the new definition of Takotsubo now include all kind of like wall motion abnormalities, even global airway hypokinesis. You can diagnose, those with Takotsubo. And they follow up those patients for 7 years. They find really no significant differences between Takotsubo, the apical ballooning tap, versus other regional wall motion abnormalities versus global hypokinesis tap. And they further combined the apical ballooning and the other type of regional wall motion. Still, they didn't find any differences. This actually raises a very interesting questions. So is Takotsubo really a cardiomyopathy, or is just a reflective of all the other organ system disease? Yeah. So those parts are considered like had a Takotsubo, but once it got transplanted into another person's, they seem to function pretty well and with no significant differences when compared with like the rest. Yeah. So this is the take-home message from my presentation. First, like obstructive coronary disease is not a contradiction for Takotsubo. You can still diagnose Takotsubo as long as the obstructive coronary disease cannot fully explain the wall motion abnormalities. Secondary Takotsubo is very it differs from primary in terms of the pathophysiology, clinical presentation, and outcome. Also, the primary medical condition will impact the clinical presentation and outcome of secondary Takotsubo. So whether Takotsubo is a marker of severe disease severity versus it can cause a direct, is a direct contributor to the mortality remains to be explored. This is the end of my presentation. Thank you, everyone, and welcome for any questions. Yeah.
Pengyang, thank you for sharing this talk. And again, here's the CME credit code for everybody attending. And please either speak up or place any questions in the chat. Many of us, as the diagnosis of this is the frequency in which we're diagnosing it has increased, are seeing patients with a history of and recovery from Takotsubo syndrome in clinic. And are there any recommendations that societies or you have for these patients for long-term surveillance or treatment? And what if they have another planned stressor in the future, like a big surgery or or ongoing anxiety or emotional stress. Are there any medical recommendations that are there for people with a history of Takotsubo?
Um, Thank you, Dr. Shah. This is a very interesting question. Actually, it's a very good questions. I would say unfortunately there's really no evidence-based treatment for Takotsubo other than the ACEI, which could prevent or reduce the risk of recurrent Takotsubo. So I will say for every single patient with history of Takotsubo, ACEI will be the first treatment choice. And we know that certain medications can trigger Takotsubo. I think for those who had a history of Takotsubo may consider avoid those medications if possible. Yeah. And definitely early identifications is important for those who had a history of Takotsubo, since there are cases of like recurrent Takotsubo being reported. Yeah. Um, I think that's probably what I will do. Yeah.
Does anybody have any questions for Dr. Li?
Uh, I saw a question in the chart. Is there a per
Predilection for female versus male patients?
um yeah, so the female patients definitely are more likely to develop Takotsubo either from the primary or secondary. But in primary Takotsubo, the female patients account around like more than 80%, which is less in the secondary Takotsubo cases. There are several different they actually have intertalk prognostic and diagnostic tool, which you can use to assess their risk by putting their ages and the risk factors for that. What do you think about the? I hope I answer your questions. What do you think about the beta-3 receptor activation hypothesis with the TG mouse mode of TTS? Does this imply anything for possible recurrence? Thank you, Dr. Laflache, for these questions. Um, I I have to be honest, like I'm not quite familiar with this mouse mode of Takotsubo, but I know that so far we do not have a good animal model to start this. And most of the animal models of Takotsubo are from, infusion catecholamines, which definitely could be one of the, causes of Takotsubo. But again, there are different mechanisms involved in Takotsubo. So far, those like beta-3 receptor activation may only explain the like some subgroup of Takotsubo cases. Yeah.
Suraj has a question. Is there any genetic predilection?
Um, as far as yeah, there are actually some genetic predilections around Takotsubo, especially the beta I think it's beta-1 receptors mutations, but again, those evidence are very limited. Yeah. So we don't have a large scale studies on the genetic variations or any like genetic mutations related to Takotsubo, as far as I know. Yeah.
And has there been any data out there suggesting that people who are on previously on beta blockers have a lower incident rate of Takotsubo? So say just comparing populations, and if you were previously on a beta blocker, is the incidence of Takotsubo lower or the event rate?
Well, no, but there are several studies that focus on the like beta blocker in the treatment of Takotsubo and the beta blocker on the like preventing recurrent Takotsubo, none of them find any significant changes on putting the patient on beta blocker. Yeah.
And there's another question here. Should we recommend prophylactic ACE inhibition if grieving is expected to happen?
Um, I so far I don't think we have any evidence to support this, since like ACEI can help prevent the recurrence of Takotsubo. And if the patient never had a history, I don't think we have like strong like evidence strong enough to recommend the prophylaxis of this. Yeah.
Pengyang, to answer some of these questions, and you may have mentioned it in your talk, are there any ongoing registries of patients with a history of Takotsubo? And is there a chance that we can participate in that, or are we
Yeah.
participating?
So basically I think there are one of the biggest one is in European. It's called Intertac registry. There are more than like they have now more than 4,000 of Takotsubo cases, and uh, they include most of the patient in European, but also some like the U.S. Hospital, also the participation sites. VCU is not a part of it, but I have been cooperated with some authors from the Intertarc registry team. Yeah, yeah, we definitely can try to see if it's possible to be part of it. Yeah.
All right, one last question. To identify cases of secondary Takotsubo syndrome using registries, did you use some ICD codes or were you able to confirm the diagnosis clinically?
Well, it depends on like what kind of the study we did. So for those using the public database like NIS, yes, we use the ICD code, but we use a very strict criteria. Basically, the patient needs to have a ICD code for Takotsubo, and also need to have like a coronary angiogram without any stem placed. So basically we use like three like SED code and to identify those patients. And also so for the case series or like meta-analysis, for each case, we use the European Heart Society diagnosis criteria to screening every single case report before we included them in the analysis. Yeah.
All right. Well, with that, thank you everybody for your questions and attending. Pengyang, thank you for all your great work and congratulations. We look forward to working more with you next year.
Thank you. Thank you, Dr. Shah. Thank you, everyone.